going to start our rural healthcare session in 61st APAN meeting. So first, I would like to start from introduction. I am Dr. Uday Koirala, surgeon and chairman in Telemedicine Society of Nepal, surgeon in Kathmandu Model Hospital. So I have our friends Jagdish Rauniar is here, so he will introduce. So please.
My name is Jagdish Ronia. Now I'm engaged in Nepal Digital Association, and we are looking after digital economy, digital health economy, rural care, health economy, etc.
Thank you. We have Dr.
Hello, good afternoon everyone. I'm Dr. Razbhai Gangur, working as a general surgeon in Kathmandu Model Hospital. Thank you.
We have Dr. Subhas.
Hello, I'm Dr. Subhas Thamola. I'm now doing my fellowship in minimal invasive surgery in Kathmandu Model Hospital. Thank you.
Okay, thank you. Thank you. So I'd like to ask from Temdek, please say hello to everyone.
Hello, this is Shantara from Temdek. Looking forward to your session, as always.
Thank you. Yukiko, are you there?
Yes, hello. Nice to see you in Zoom again. I'm looking forward for this session. Thank you.
Thank you. Next, Nepal Research and Education Network.
Good afternoon, everyone. I'm Nirajan Parajuri from Nepal Research and Education Network.
Thank you. Pranit Pokhrel.
Good afternoon. Good afternoon, everyone, and thank you very much for this opportunity. I am Dr. Pranit Pokhrel, currently Dean, Karnali Academy of Health Science. We are one of the institute that is really located in a very rural part of uh, Nepal, and even in the world. I think because 2,400-meter high above the sea level, there are very few medical schools, and we are very much interested in this rural health. Thank you so much for this opportunity.
Thank you. Thank you, Dr. Pranit, to be connected. Thank you very much. Fumiko. Fumiko. Okay, Lokesh Gupta ji.
Hello, good afternoon. I'm Lokesh Gupta from Nepal Digital Association, and I work as a technical expert and as an IT expert. Thank you.
Thank you. Rasmila. Okay, then now we are going to start our session. This time we have 4 presenters. So first presenter is from KPAS, Dr. Binita Kharel from US. Because of the time difference, she has sent this recorded video, and now we are going to play this video to all. She is running KPAS, and she is the president of KPAS, which is supporting Kathmandu Institute of Health, Child Health in Nepal, and she is running a home care service in USA. So she will be explaining about a home care service.
Hello everyone, namaste. Today I want to talk about a massive shift that's happening in healthcare. And no, it's not a new wonder drug, it's not a breakthrough procedure, it's not a futuristic machine. It's something far simpler and far more powerful. It's about using the technology we already have in our pockets to finally get care to the people who need it the most. It's about digitalization, digital transformation of healthcare. Before I go further, let me share why this topic matters so deeply to me. Because this isn't just a professional interest, it's personal. A little bit about me. My name is Benita Korenlapal. I am an internal medicine physician and a medical pod leader in Dallas, Texas, where I practice home-based care, combining house calls and telehealth to care for elderly and medically complex patients. I was born and raised in Kathmandu, Nepal, so I carry two perspectives with me all the time. One from advanced healthcare system and another from communities that are resilient, connected, digitally enabled, but still struggle to reach care when it matters the most. That dual perspective is why I'm deeply passionate about preventive healthcare, equity, and access. Because I've seen both sides of the world, that when care arrives early, when care arrives at home, everything changes. Which brings me to the question that frames everything I want to talk about today. So, what if the biggest innovation, the most revolutionary thing to happen in healthcare is not medicine or isn't a new pill or a new hospital, but a new way of reaching people? Care without borders. This is not about innovating medicine or replacing doctors with technology. It's about amplifying clinicians or extending their reach. Like in Nepal, we have mountains, we have remote villages, doctors are concentrated in cities, mostly Kathmandu, but cell towers, they're everywhere. So let me start with this mental image. What happens when someone needs medical care, but the nearest doctor is hours away? Not minutes, not a short ride, but a journey over hills, broken roads, missed wages, borrowed money, delayed hope. Across the Asia Pacific region, from dense cities to remote villages, millions face this reality every day, and yet almost all of them carry something extraordinary in their hand: a smartphone. We live in a country where a video can reach mountain village in seconds. A message can cross districts instantly. Money can be transferred digitally. Children attend online classes, but healthcare still asks people to travel, still asks the elderly to walk, still asks families to choose between care and cost, and still arrives late when the disease has already progressed. Technology it has reached every hand, but healthcare has not reached every home. So, in the Asia Pacific region, we share some common challenges like large rural populations, aging communities, rising chronic disease, limited specialists available outside cities. But also, we share some strengths like strong family involvement, community-based care traditions, and rapid digital adoption. We have high-speed internet in our pocket, but the nearest doctor is still far away. And this is a paradox: high-tech, low access. But what happens when care comes home? As I mentioned earlier, I go to patients' houses to see them. So let me share one of my stories. An elderly patient constantly was in the hospital. She got admitted, discharged, got readmitted. The care team was frustrated. Her family was exhausted, but medically, her condition wasn't a mystery. Her medications worked, the treatment plan was good. So, what is going wrong? Timing. She would slightly feel worse at home. She would be more breathless, her leg would be more swollen, but care felt far away, and she didn't want to be a burden. So she waited. And in that small delay, a manageable issue turned into an emergency. I call it the cycle of too late. But then we changed one thing, not the medication, not the diagnosis. We changed the logistics. We added home visits and simple telehealth check-ins. We adjusted her medications on a Tuesday morning so she didn't land in the emergency room on Saturday. And everything changed. She stayed stable, she stayed home, her family could finally breathe again. So remember, the medicine did not change here, access did. The molecule in the pill was identical. The only thing that was changed was how the care reached her. So this is where idea of utilizing digitalization, digital transformation as the access multiplier comes in. And despite how technical it sounds, it's deeply human. So digitalization will allow us to extend reach of limited clinicians, support community health workers, shift care from reactive to proactive preventative care, and bring expertise without relocating them. It is about scaling the community care. So let me describe this model that is not futuristic. It is not expensive, it is not complicated, and it already exists. Using simple digital tools and existing local community health workers to scale the reach and impact of human-centered healthcare. So this is how the model looks like. A community health worker, someone who's trusted, someone local in the community, they visit the patient at their home. That person provides the physical presence, checks blood pressure, vitals, check leg swelling, physical examination, and go over the symptoms. Then they pull out the phone and suddenly a physician or a specialist in the city is virtually in the room now. So this isn't just a telemedicine, it's a triad. The patient, the community health worker, and the remote physician. The health worker translates, not just the language, but meaning. They ensure the patient understands and performs the physical exam the doctor cannot do through the screen. Now think about it as a multiplier effect. One doctor, without leaving the desk, can support care across dozens of villages in a single afternoon. Their expertise is multiplied. The health worker feels empowered. Care reaches the patient where they are before the crisis happens. So let me say this clearly again. This is not about apps. This is not about platforms. This is not about innovation buzzwords. This is about utilizing simple, powerful digital technology to improve healthcare access to patients while extending the clinicians. And digital healthcare does not need to be perfect. This is where many of us get uncomfortable. We say that digital healthcare must be perfect before it can be used. Encrypted, interoperable, ideal. But here's the truth. Digital healthcare does not need to be perfect. It needs to be present. Presence over perfection. Is it as secure as a bank vault? Maybe not. But ask the harder question. Is no care at all safer? The risk of no access is far deadlier than the risk of imperfect data security. And when you lower that barrier, the first benefit isn't better lab values, it's dignity. It is about allowing that elderly patient to receive care without them having to beg to a neighbor or a family member for transport. It is about family member not having to choose between work and taking their parent or spouse or child to a distant clinic. It is about catching illness early before families are pushed into poverty by healthcare costs. Dignity is being treated at home, surrounded by family, known by name, not just by a bed number. And the system wins too. Early care prevents expensive hospitalization that saves enormous healthcare resources. And what happens when care comes around home, around people? People seek help earlier, chronic diseases are controlled, hospitals are used for what they are actually meant to be used for true emergencies. Trust in healthcare system grows, and perhaps most importantly, people feel seen. We all know that doctors everywhere are overwhelmed. This model lets them focus on decision making, the work they are trained for, without the burnout. Patients win, families win, and health system wins, and clinicians win. But we might think, why isn't this already a standard everywhere? Because implementation matters. And the answer is not to change everything all at once. You do not want to boil the ocean, right? So you pilot, you learn, you scale. We start with one care team, fix the glitches, measure the outcomes, and then replicate what works. This is evolution, not revolution. And we may ask, why does this matter now? Because timing is now. The digital infrastructure already exists, the burden of chronic disease is rising, the workforce is stretched thin, and patients know what's possible. A mother who can video chat with her son abroad will not accept that she cannot reach a nurse nearby. And patients are demanding convenience and dignity. So digitalization is no longer optional, it's essential. And to the healthcare professional in this network, you represent systems, cultures, and countries that understand both the constraint and the creativity. The future of healthcare access will not be built by technology alone. It will be built by leaders like you who choose to redesign care around people, not places. Technology alone does not heal anyone. Healing happens when leaders like you decide to use that tool differently. When policymakers, hospital administrators, and clinicians shift from build it and then will come to go where they are. We have already conquered the physical barriers, but what remains are the mental and the bureaucratic barriers, which means this is no longer a technology problem, it is a choice. So let me close with this final thought. If technology can cross oceans, if knowledge can travel instantly, if care can be delivered digitally, then access should never be the limiting factor. If a phone can reach every hand, then healthcare can reach every home. Thank you. Hello, everyone. Namaste. Today I want to talk about a massive
Okay, thank you, Dr. Milida, for excellent presentation. Next is Amrit Ranawat. He will be presenting the next presentation. Amrit, sir.
Hello. Yes, sir. Sorry, is my sound audible?
Yes, yes. Can you share your slide, please?
Yeah, okay, sir. I'll be sharing. Just a minute.
Amritsar will be presenting on SDGs. SDG as indicator for digital transformation in rural healthcare.
Sir, is my slide
Yes.
it's visible?
Yes, it's visible.
Okay, sir, I'll continue, sir.
Okay. Can you make it full screen?
Sure, sir.
Okay.
Sir, it's visible now?
Yes, yes. So here are some new friends have joined. Dr. Moriyama, will you say hello to everyone?
Hi, hello everybody. Sorry
Ah.
for my late. I have
No, it's okay.
another business in the hospital, so that I just have arrived, so that I would like to enjoy the session. Thank you so much.
Will you please introduce yourself as well?
I'm Moriyama from Kish University Hospital, the TEMDEC, director of TEMDEC, and this is we are organizing this kind of not organized, but to support the technically about this session. Thank you so much.
Thank you. Abhimanyu Pandey, will you please introduce yourself? Abhimanyu?
No, namaste. This is Abhimanyu. I'm with two other gentlemen, Pranjal Pathak and Pawan Sakya. And we are in part of Telemedicine Society of Nepal. And thank you for the invitation. Thank you.
Thank you very much. Okay, Amritsar, can you please start your presentation?
Okay, sure, sir. Okay, so the topic that I'll be talking about is the sustainable development as the indicators for the digital transformation. So basically, we are talking about how we can transform, especially for the healthcare in the digital world. Because side by side, we are talking about the sustainable development in the different field, like the quality education for us. For my introduction, I am senior software engineer working in the MSC company. It's Australian based, and I have expertise in the AI and machine learning. Based on the project that I have been dealing with, I have found that the multiple projects are based on the health. So similarly, for the sustainable development goals, I have been awarded with the SDG 4 for quality education and the SDG 9 for digital and the engineering field. So at first we know about what exactly means what sustainable goal number 3. It basically deals with the good health and the well-being. So it basically deals with the quality healthcare for all. So it basically deals with decreasing the disease and its rate and mental health and well-being. So similarly, how can an individual or that community can afford and access that health services in the decent period of time? So while talking about the SDG goal number 9, it basically deals with the digital and the physical infrastructure. If those healthcare services are in the sophisticated and in the sustainable field and the technology and invention for the research and the development, and if we can relate that healthcare with the sustainable industries. So based in our country, Nepal, I'm talking about, so we have been talking about the sustainable development in the different field. Being from the IT sector, I have been involved in the different remote areas of the Nepal. I found that based upon the IT background, I have seen that people still don't know about how to operate the PC. We are talking about the rapid development. We are talking about the artificial intelligence, machine learning, and the deep learning concept. But still, there are the remote areas of the people, they still don't know how to operate the PC. And similarly to the IT field, and there are the several areas that has not been able to access the healthcare in a decent way. So we have to build one technology so that we can bridge the gap. Basically, we can see that in town areas, in well-developed areas, the health facilities are well. And similarly, if a person suffer from any sort of disease, then in town areas he can easily get in a certain period of time. But what about the remote areas? We have developed some technology, but still many people in the remote areas are still able to meet the right amount of treatment in the right amount of time. So there are some critical barriers that has been leading to that the SS. First one is the geographical isolation. Is we know that Nepal is a country situated in the lap of Great Himalayas. Hilly areas is there, basically tri areas there, and three different belts are there. So due to that different belts, the physical access has been a problem. Similarly, the workforce shortage. In cities areas, we can see the well-managed and the skilled doctors. But what about those remote areas? Similarly, the infrastructure deficit. They are not able to get exactly the right amount and the well-managed infrastructure that has leads towards a bit challenge in the remote areas of the Nepal. So SDG 4, so being from the Sustainable Development Goal, SDG 4 basically deals with the quality of education. Is many people still don't know about what are the latest technology in the healthcare that the people can get benefit from. We are only seeing about the advanced areas. We are talking about the developed countries. But how can SDG goal number 4 can be relate in the context of developing countries like the Nepal? So it means we have to educate as much as possible. We have to create the campaigns. We have to create one programs in the remote areas of the Nepal such that the people can know exactly about it and we can move towards the destination. So basically, I have focused as the quality education as the fundamental pillar, because if people know that in the healthcare we should be and various telemedicine protocols, empowering that we can create one all-in-one platform such that based upon that platform, each and everyone can utilize it. If so certain people have any sort of healthcare problem, then directly through that platform, all-in-one platform, they can consult being based from the remote areas to directly to the main doctor. Because basically we have seen that physically some patient may face difficulty to directly talk to the doctor. In that purpose, it can be one of the best platform. Similarly, EHR system mastery is a bit, if we can ensure that data in a decent way, if we build one model that can sustain for the a long term, then this sort of training should, I think it should be promoted in the remote area, such that the town and the remote areas can be go side by side. Though there are the barriers, but first and the foremost thing is the education should be maintained in the remote areas. The training awareness program, various sort of activities should be conducted in the remote areas, especially in the developing country like the Nepal. So to conclude, a digital transformation is what the human actually transformation. So as we are in the digital world, that transformation should be needed. So SDG 4 in action. So basically, while talking about so SDG 4, transforming the health education through the curriculum revolution. So basically, if we introduce this concept from that curriculum wise, subject wise, this concept from the childhood, then obviously this concept can be extended throughout the country. So the Nepal Medical Council has initialized digital health or mandating the proficiency for all the medical students. I think that this field student should expand, should create those problems in each and every part of the Nepal such that they all will know about the quality education. Developing the technical skill for the youth as well as for all generation people. ensuring the learners acquire the knowledge for the sustainable development, and we should take the action in a decent way, not for the one period of time. If we conduct one campaign in any remote area, then it should sustain for the 3-4 years, so that the legacy will be maintained. Similarly, the EHR system, telemedicine, and the diagnostic proper explanation and interpretation should be there. So SDG 9 basically deals with the infrastructure, how we can make the development and the technology in a faster way. A network explanation. So as I have already talked about, we should take that remote areas and the cities areas side by side. The challenges that might be faced is through the communication in one platform, because all the area of the country cannot get the equal access in terms of internet. So how we can lead the digital lifeline? So it's from the government sector also, some sort of help should be there. That universal internet access that comes under the SDG 9.6, turning report clinics into the national networks nodes. Similarly, solar power resilience. Clinics wise, AI diagnostic for the TB and the diabetic in off-grid regions. Further, measurable outcomes, it ensures that moving from the required evidence to the hard metrics, reliable access and the unique deployment. So SDG 4 and the SDG 9, the quality education as well as the infrastructure are the basic backbone. And if we can take this in a parallel way, then obviously we can reach towards our destination. So while talking about the innovation in the rural connectivity in the hardware, is for the developing country that has the 3 different belts: Himalayan region, hilly region, and the Uttara region. It's sort of challenge to take all those belts in a parallel way. So how we can take it? So solar powered clinics, AI powered diagnostic, and further satellite built health. So this sort of advanced technology we can apply. So SDG indicators is a measurable success metrics. So how it can lead actually? So here is some sort of headlines, the high headlines, threshold of benchmark. Skills SDG 4.4 is about the skill acquisition. Measures the digital literacy of the healthcare workers. Its target is 80%. And while talking about the infrastructure coverage, evaluates the broadband stability and the hardware resilience. That covers around more than the 70% coverage. So policy integration, because we are talking about that development should be go especially for the healthcare, that telemedicine concept should be included in each and every area of the developing country. So policies should be mailed from the concerned authorities. So SDG 4 and SDG 9, I believe, equals to a sustainable impact. The policy mandate, the dual assessment, including both the SDG 4 and the 9. It should ensure the hardware investment match the human capital development too, and creates one virtuous cycle. It includes skilled workforce drives and infrastructure use. So the outcome of moving beyond the pilot project to systemic scalable change. So I have also compare the SARC regional application. So impact on the consultation success rate. So before the implementation of the project, so it was the 42%, and after the completion, it leads to the 89%. So what sort of SDG framework we shall build a model? Standardize a digital literacy curriculum for the frontline health staff, a systematic and a well-managed curriculum that includes the digital literacy. So should be include. Similarly, the infrastructure resilience. So solar powered mobile clinics, ensuring the 99.9% up to in the remote zone. So SARC region application for the Bangladesh, India, Bhutan, Pakistan, Sri Lanka. This concept implementing a national digital health curriculum, leveraging SDG indicators for the real-time health system, scaling the satellite-based EHR system across the high-altitude terrains, adopting the solar power clinics for the advanced in the flood-prone district. So 320 plus rural health workers successfully trained and integrated into the digital world. So call to the action. So as an SDG award, it does not mean that I'm talking from the being from the tech ground. I see many of that IT specialists. Yeah, if you talk about the IT engineering student, they don't want to be interconnected with the health related project in the research. So from the base also, we have to lead that IT sprint, that the healthcare projects should also be taken side by side. So if they, because I have been worked in the remote project based on the healthcare, so as being the developer, I have faced that they give their own data set, and while working on that data set, the engineers sometimes have to study the same class, because as being from the tech background, I have seen that I have to first study the system, how that healthcare management system works. Then after that, we have lead to the deployment of the model. So I asked Sark Nation to transit from the pilot project to the systematic transformation, embed SDG 4 and the 9 at the core matrix, standardize the health related curriculum, invest in the solar power infrastructure, no community left behind in the digital health revolution. So that such that the sustainable development goals in the healthcare, in the quality education, and the infrastructure can be go in the parallel way, and especially the developing countries, it will be the plus point for the them. Thank you, sir.
Amritsar, for nice presentation, and really you connected very nicely this SDG with healthcare and of course the digital transformation of health in rural healthcare. Thank you very much. So we'll be connected. Next is presenter is Jagdish sir. He is with me. He will first introduce himself and then start his presentation on digital health economy. Thank you. Can you please stop sharing? Yeah. You, sir.
Oh.
So is the screen visible to you?
Yes, sir, it's visible.
Once again, good afternoon to everybody. My name is Jagdish Runia. I'm associated with Nepal Digital Association.
Rojan, it's in presentation tool.
Pardon?
It's not in full screen.
Oh, okay, Rojan is. Now, see now?
No, it's in presentation tool. We can see the.
Oh, full screen, sir. Make it full screen.
Full screen, sir.
Okay.
Cancel.
Press display settings. Rojan, can you press display settings on the top?
Yeah.
And duplicate slideshow.
Now?
Yeah, okay, now okay. Thank you.
Welcome.
Okay. Thank you, Rojanji. Once again, good afternoon. I'm Jagdish Hunair from Nepal Digital Association. Today, I'd like to introduce a new topic, that is digital health economy. I have three things I like to mention, three different phases of evolution of digital health, how it is moving from e-health to digital health economy, and why we should more concerned about the economy side than the technology side. So let me start with the first, the e-health, that is based on WHO 2005 resolution, e-health resolution. So Nepal has also adopted e-health strategy in 2017, and telemedicine, rural healthcare is one of that uh, part of that strategy. So there was a very primitive stage of rural healthcare digitization, or the concept taking, or the ideation stage. Uh, then we come up with the roadmap, and then we start taking ahead little bit by bit, the concept getting into the mainstream and so on. Then in 2018, WHO come up with 2000 digital health resolution in 2018, and in 2021, 2022, Nepal started uh, graduating from e-health to digital health, interoperable solutions, various SS solutions, last mile solutions, connectivity, and uh, various other factors to consider. So within this 4 years range, we have plenty of discussion on digital health, uh, for the rural healthcare, for the universal health coverage, and health inclusions. Uh, Now, at this moment, we must think about digital health economy, the investment, the cost, the economy size, how to measure it, and how can we realize it at the ground. From political economics perspective, we see centuries old political economics. If you see the lessons, there are two factors that is input or to the any production system, that is the labor and the capital. In modern sciences or modern world, we say HR, technology, and capital, the three major factors for any production systems to happen, any economy to build, to run, and sustain and grow. For digital health also, and rural digital healthcare, we need these three factors: the human capital, the technology, and the capital itself. Without that, we cannot realize it at the ground level, because there is a vast infrastructure we require. The geographical disparities are there, the infrastructure, the training, and the digital literacy part is there. So we need to build investment around that. So the economy, what is the economy now? So for digital economy, that's why we introduced this concept, that digital health economy. And recently we had our conference held, fourth telemedicine and first digital health conference, and we have come up with this uh, ideas on the conference. That's let's size this sector. What is the size of digital health economy? And within that digital health economy, we can create a chunk of rural digital health economy. So what should be the size? So the first question is sizing this economy. So what should be the size? Then we can identify the public spending, how to improve the public financial management for that investment, and what are the public sector investment, and how to achieve a demand supply equilibrium. Because without understanding a clear demand and estimating that one, we cannot estimate the our investment. We cannot create the supply system, what is the supply requirement, and no firms or no public institutions can join because of lower ROI. So The second question is achieving domestic demand supply equilibrium. So that is the focus, that is Nepal focus framework that we are developing, working on Nepal Digital Association. And this is very relevant to the regional settings because if you go to the SAARC countries or BIMSTEC, similar things happen there. We talk more about the technology, more about the human resource training, the digital literacy, but nobody is talking about the investment. What size of investment is required? So let's first discuss about the demand size. Demand side. What is the demand side for the rural healthcare? We have reviewed plenty of models throughout the globe, and we find a best model that fits is the EU DESI model. That is the digital empowerment and social inclusion. So we derive from there the healthcare, rural healthcare inclusion should be a part of universal health coverage, and that is always a part there. But digital health should consider that one. So in 2023, EU has come up with a new set of digital health indicators. That is, one of the indicator is 100% access to 100% population access to their medical record or EHR. That is, so that is one of the indicators they have set. So we can imagine the rural population we have and the size of infrastructure, EHR infrastructure we need to build in terms of DPI so that they can access to that EHR, their medical records, they can consent to doctors, they can send to various health workers for their history reviewing, and so they can better treat the patient. So that is the demand we have. So this is a massive investment project. This is not a small technology project. So that is the demand side we observe. Now, moving forward to sizing this economy, I will come to mm, this one slide. Okay, I'm just to skip this up, some of these slides so that we can focus on. So this is the Desi style readiness, uh, payment and SDG linked healthcare targets. So this is more about the demand side. Mm, I just quickly come to this point. Yes, this one. The sizing, how to size the digital health economy and how to extract it because we have recently not very much work on we haven't got much work on rural healthcare economy, digital health economy. So what we suggest is two methods for estimation of digital rural healthcare economy. So the first is estimating the total universal health care, digital healthcare economy size, and the second is virtual healthcare economy size. So the first part is this one, digital health economic size. So what we have done is we have taken 25 to 35 up to 35 GDP projections from Nepal Rashtra Bank, that is the central bank in Nepal. So this is the GDP growth and GDP size. Now we have estimated the digital economy size. So for 4 to 7% of this GDP should be the digital economy size, and this has been taken from uh, the initial. One more slide I have. Okay, anyway, so there is we have taken from the benchmarking from India and China. So China already has acquired significant more than one third of GDP from contribution from digital sector. That is 38.6%. That is back in 2021. So that is already achieved by China, and India has started 20% of their GDP that is contributed from the digital sector. So on that benchmark, we have just interpolated this data to reach 20% of the traditional GDP into digital GDP, that is 17.4%. And now we have from World Bank, we have got for Nepal data, it is 6.6% of total GDP spent on health sector. So the same data we have taken for interpolation 17.4%, that is the data. So we have taken this one 1.148, this for digital health spending, and this is 93 crore, that is the NPR, okay, Nepalese rupees, in 93 crore Nepalese rupees. That is by 2035. That is the digital economy, and 66% of this is 6.143. That is 6.143 crore Nepalese rupees. That is the cumulative digital health spending, total spending that we have projected. So this methodology gives the total economy size of digital health for to achieve universal health coverage. So a digital economy size gives you the public spending, the private sector investment, and the import and export of digital products and services uh, in the digital health sector. So that the total collectively known as digital health economy. So here is the public spending, the private investment as well. So from this one, this is the first method. The second method we have employed is virtual care, estimating the size of virtual care. So return on investment or impact on investment is a major tool for investment. So we have more than 5 million population are in foreign employment. We have estimated the economic losses that due to death in the that we have evidence from the previous decade. Within the 13-year range, there have been more than 10,000 deaths have occurred. So we have accumulated by 35 how much economic losses, foreign exchange reserve can be losses. So we have accumulated that one into $2.8 billion. So that accounts for. So economic losses, a country Nepal, country like Nepal, which is heavily dependent on remittances, more than 20%, or 25%, that is contributing in GDP. So we are losing by 2035 $2.8 billion. So out of that one, only 15 to 20%, if you can invest, we can protect this $2.8 billion, this economic losses. So that gives a measure of another virtual care. So once we set up this economic parameters for the virtual care or the telemedicine for the foreign employee, we can easily extend this to the rural health care in Nepal, because it is very hard to estimate economic losses in the rural healthcare. We don't have such a huge data. So, so these two methods we have employed for the digital health economy um, estimation for the rural healthcare. So, there are two. This is my last slide. I'm concluding this with. So, how to achieve a demand supply equilibrium? So the first is that we have to increase, uh, we have to digitization of rural healthcare to achieve universal health coverage. So we have a wide range of population that we have to cover. The second, wide range of services, the diagnostic services, the clinical services, the preventive services, that we have to carry to the last mile people, to the rural healthcare. So that is the our the demand side. That is the demand side. So digitization of the universal healthcare, universal healthcare accessibility to the rural population. So that is the demand side. And on the second part, the supply side, They are the startups. They are the very small startups that have been built around the ideation, the new innovations. We need to fund them. We need to sustain them, grow them, and we need to build into a private sector ecosystem so that can align with the digital public infrastructure of the public system. So these two will build the supply system. So rural healthcare digitization is the demand side, and digital startup industrialization is the supply side. And achieving this um, equilibrium is the achieving this equilibrium is the method to achieve demand supply equilibrium, and the fueling factor is the investment and economy size of this investment. So that is, and this is how I conclude my presentation. Thank you very much. Thank you.
So thank you, Jagdish Oniar sir, for very elaborative and nice presentation. And it's also eye-opening for us, like how we can plan this economy, digital economy for the rural healthcare. And maybe we can mix up this digital health economy concept with SDG concept to build up our basic idea or minimum standard for digital health transformation in rural healthcare. Thank you. So next presentation is from Mr. Vishal Timil Sinha. He is founder of Biomaxis. So Vishal, please first introduce yourself and start the presentation. Thank you.
Okay. Hello all. I'm Bisal Tinsina. I'm founder of Biomaxis, which is a health tech company based on latest standards like FIRE, Smart on FIRE, and other clinical decision system standards like CDS-hooks. And today I'm going to present about on the topic of digital health standards in rural healthcare. Let me share my screen. I just wanted to confirm if you can see my screen.
Yes, yes.
Sure, thank you. So about me, continue on the introduction. I've been working on the national and international health tech for 7+ years, and mainly on the standardization and mainly in the US healthcare, after the high tech law and the TEFCA. So, and we are trying to implement the similar standards and technology in the Nepal. So, discussing about the standards, let's start with the problem why we need standards. So, in the current scenario in Nepal, most of the health data are in the paper, and so we can even it's not digital format. So, get like the structure for the standardized is like the far face idea. So, and all of the system are fragmented. So even if some of the system, if some of the hospital are in the digital, they are adopting the digital EMR, but they are still using their own standards, and that is making the cost of for the government a huge burden. So every local municipality or the local level, they buy their own EMR and they implement it in their own. And so in Nepal, there are around like 753 municipalities and almost 5,000-6,000 ward level. And if every ward they implement their own EMR, then it will be a big burden for the country. And there are some reporting system in Nepal, but most of them are manual. And since all of this system is fragmented and unstructured, in rural setting, there is less hospital and there is less providers. So uh, there is the patient depends on the referral system, and once the patients are referred from rural setting to the urban setting, they need to do the test again, and a lot of the money is spent on test, and also a lot of the history is spent. lost when they go from one place to other place or from the one hospital setting to the other hospital setting. And talking about the standards, so standard is like is a grammar for the health data. It defines how this data is captured, and let's say there is some observations in the lab setting. So standards help make it that all of the hospital agree on the same vocabularies and terminologies, and also it means how the data that is captured in the standard vocabularies are presented on some structural form, and also about how the data are exchanged or transmitted. It could be from one department to the other department, from one health device to the other health device, or it could be from one hospital to the other hospital. And all of those means that the data is not ambiguous and they are interpreted in the same way. And all of the providers or the hospital, they get the same meaning of the data. And talking about the key standards in the healthcare settings, there's a one called FHIR, which is like the most popular standard right now and adopted by uh, maybe 50, 60 countries, and that is explored by almost all of the countries in the world right now. And FHIR defines how the patient data and the clinical records are standardized in the international global standards. And the next is about the vocabularies. So some of the key vocabularies here are SNOMED, which is the vocabularies for diagnosis and clinical terms, and ICD, which is the vocabularies for the conditions, and LONC, which is for the lab setting and the observations, and DICOM, which is the standard for the imaging. That means all of the images from the radiology department and pathology and dermatology and others. So who makes standards? So there's a lot of different kind of standards. So in the case of FHIR, it is mainly in the responsibility of CASL 7, which is a consortium of the major health organizations. And also there are some standards that is globally defined. Let's say for the ISO, it defines the unit of measure of many things. And for the imaging, there is the DICOM format. And also there are a lot of organizations that makes standardized vocabularies like SNOMED, and LONC, ASTM, and CEN, and other organizations. So about the health standard timeline, there's a long history about digitization and the standardization of health data. So YATSOSEN V2 itself was first published in 1987, and DICOM is started from 1993. And there have been a lot of iteration in both of the format. Let's say in the 2000, there's YATSOSEN V3, and there's the CDI, Clinical Document Architecture, in 2005, which is the continuation of SL7 V3. And the initial FHIR standard, it was introduced in 2010, mainly from Australia, by Grams. And since it was based on the modern standards like JSON, it can also be denoted in XML, but it is mainly used in JSON format, and it uses latest web standard like REST. And for the terminologies, it gained a popularity in the short span of time. And also one of the reasons it gained popularity was it was more extensible. So we can extend the file profile on our own. So the system is less rigid, making adoption more easier. And there was a smart on file. So smart on file means FHIR defines how the clinical data is recorded, and smart means substitutional medical application and reusable technologies. So it defines how we can make the mobile apps or the web apps on top of the FHIR standard. So those apps can move from one clinical setting to the other clinical setting, or from one EMR to the other EMR. So it helps to create an ecosystem around the health data applications. So and everybody can benefit from the ecosystem. And in 2017, there was a release of FHIR R4, which is the first normative release, and the adoption of the FHIR was really accelerated after the release of the before. And in 2020, there was a rule for TEFCA, so that makes all of the hospital and EMRs mandatory under the so they still share the data under the FHIR and it's not on FHIR standards. So and why standards matter more in the rural setting? I feel like standards are more important in rural than in the urban. Like it's of course it's important in both setting, but there are some reasons that makes it more important in the rural setting. So one is there are a lot fewer specialists and hospital in the rural settings. So that means the patient there is more referral system. So when there is referral, there is a issue of the continuity of the care. So once the patient does some checkup in the rural and the rural hospital refer them to the urban hospital, all of the tests or the documents and knowledge is lost, and standards and interoperable infrastructure will help reduce that gap in the knowledge. And also rural settings, since there is less resources, there's a limited diagnostic. So if you can standardize and make the system more interoperable, we will have more data to do the diagnosis. And also if we can use clinical decision support system across all of the hospital, we can reduce the amount of cost to develop those clinical CDS system, and that will make the diagnosis system more better. And also in the rural setting, maybe across the global, but I know only from the Nepal scenario, most of the doctors, they don't want to visit the rural area, and there is a very high staff turnover. So with every staff turnover, if you don't have any standard, that means they have to go through all of the onboarding phases. Once again, they have to understand how the system works and how the knowledge is organized, or how the data is organized in that hospital setting. So if you demand some consistency and standardization in the national level, then they don't have to go through all of this process again. So they can jump into the clinical setting and the decision setting faster, and which will make better outcomes. And the next is higher cost. So it again binds to the referral system or the continuity of care. So when the patient are referred from the rural hospital to the urban hospital, since there isn't any continuity of care or the interoperable standards, they have to go through all of those clinical tests, lab tests, or the imaging tests again, and which add a lot of burden in the um, financial side for the patient. And since most of the rural people are already financially disadvantaged, and it will create additional burden for them. So if we can make the rural settings in the standardized method, then we can reduce that cost. And talking about how we can standardize rural health setting, we have divided that into multiple approaches. One is, let's say, for the tools like community health toolkit or any data collection form, we can use structured data capture instead of COBOL toolbox. Right now, most of the rural workers, when they used to collect the clinical data, they use X forms or to COBOL toolbox, and that again as and all of this data from the COBOL toolbox needs to be processed and analyzed and converted to the clinical data, and which adds a lot of burden. So, and most of the data are not standardized or analyzed because it we need additional resources for that. And there is a standard called STC, which is a standard data capture, which is the one advocated by Association Fire. It defines how we can create clinical forms, how we can capture data, or how we can edit the current data. So it can be easily converted to the fire standard. So all of those mobile application can use the STC. And also one of the advantage of STC is the form that we create in STC can be easily transferred to other hospitals. So they can just copy that code and of the form uh, and they can use the form without setting up anything extra. And the next is Fire or smart on Fire based EMR. So if it is really easy to make the interoperable health actions if we make it on top of smart on Fire, and also smart on Fire will make it will reduce the cost of the hospital EMR system, since we can all of the applications that is developed in Smart on Fire can be shared across hospital. We don't need to make the custom applications or some specialized application in every hospital. So that will reduce the amount of cost and resources. And the next is Fire on DICOM. So it's a relatively new terminology, and where the DICOM is stored in the existing format. The file are stored in the existing format, but the metadata is stored in the Fire format. So that will make it easier to develop interoperable imaging system. So we can also use that in the rural setting. So not only the clinical records or the lab records are move across the hospital, but also the imaging, which is a huge chunk of the data, will also move from one hospital to the other hospital. And in the case of reducing the cost for the hospital and also to reduce the infrastructure for the hospital, we can use the hub and spoke model. So the rural hospital can use thin clients. So there will be a main server in the urban setting, and the rural hospital can just connect to that server. It could be maybe multi-tenant server, and all of those rural hospital can connect to that server to access the data. And so the rural setting will only be the presentation layer. They don't need to set up the server and everything. And it will really reduce the amount of cost for the hospital. And also it will make a lot of other things easier, like the urban main hospital can provide the telemedicine services and other services to the rural hospital. And since the data is aggregated in the centralized way, they can all of those system can see the same data and no context is lost. And the next is a standard that is not in the clinical, but in the communication layer. So matrix is one of the specification that is mainly popular right now for decentralized communication. So maybe we can also use that for the communication between hospital, and it could act as a backbone for all of the telecommunication settings. So that means any with the matrix decentralized communication, the telemedicine also can move across different hospital, and it will make the communication interoperable, similar to how all of the health data exchanges will make the clinical records interoperable. And about the rural settings, there is even if the internet access has greatly improved in the Nepal, mainly in the last 10-15 years, there are still places where there is patchy networks um, or networks with with frequent power cuts, and we need to make sure that the system is offline first when developing, and it could be offline first, maybe just for the data capture, and so the client system doesn't need to hold all of the data when they sync later. So, and but we have to make sure they are always in the they always prefer the standards vocabularies. So the data is in the same format everywhere. And with this, I want to conclude my presentation. Give you this up.
Sherry? Okay, thank you. So all four presenters, thank you very much. So all those were very nice presentations. Uh, Here I can see Dr. Puja Lama. She is public health specialist. So Dr. Puja, would you like to introduce and say something?
Hello and good morning. No, good afternoon over there. Thank you so much, Dr. Udit, for arranging this wonderful presentation. And I'm sorry I'm a little late because of the time changes, and it has really been a wonderful presentation so far. And I expect to learn more about it. You're doing a great job, and thank you to all the presenters. Thank you so much.
Okay, thank you, Dr. Puja. So starting from uh, Amrit. Amrit is still there. So Amrit sir is not there. Sir, Lokesh sir, Lokesh sir, will you please, yeah,
Hello.
uh, hello, regarding the
Hi.
presentation and the digital health economy in rural healthcare. So, uh, what is your idea and how will you review Jagdish sir's presentation?
Like currently, I just slightly went through all the presentations over there, and what I feel currently there are three parts involved in it. The first part are doctors part, and the second part is technology, and third part is economy, finance. And for all these things, we have some other parts playing in the background, like the policies related things, the communication and the management team. And Jagdish sir currently, I think he covered most of the things related to the economy. Like whenever we plan, even we have attended many seminars and all these things where digital health economy, the field is mostly dominated by doctors, and the technology people they are very less, and the economy people who are going to finance it, they are more lesser. And until and unless we don't support it in economic way, I don't think even the doctors or the engineers they can develop an application or that would be very fruitful for the doctors and the patients. And also we would need some policies related thing in it, where might be our health ministry or other education board they can get involved in it so that we can work together and get some fruitful product. That was my insight.
Okay, thank you.
Thank you.
Thank you, Lokesh sir. Dr. Pranit is also here. So, Pranit sir, so how were the presentations and how should we take home the message from
Uh,
this presentation, sir?
yeah, thank you, Dr. Uday. It was a very nice presentation, and for someone in an institute where we are ourselves trying our best to develop the this telemedicine center, because as you know we are the only health service provider center in the upper Karnali, and the remote areas where most of our speakers were talking about lies to this geographical location of Nepal. So it was a very brainstorming and eye-opening discussions for me, and I'd like to be part of this kind of discussion in the near future also. There are a lot of challenges ahead, but these kind of the lectures, what I heard from the experts, I think this will help us definitely to grow to grow the help to the community through this digital technology. So I had a very nice learning and also eye-opening regarding the digital health economics, the loss what we are facing, because I remember every day we are referring our patients even from here due to the lack of a lot of things we can understand the medical field. We are referring a lot of patients. So and I can imagine there are a lot of patients who comes to us from very far away places, and with the help of the digital technology we can reach there. As our first speaker Dr. Pinita rightly said, we can to reach to the places. So it was a very nice presentation, all of the speakers. Thank you all. Thank you, Dr. Uday, for letting me in.
Thank you, Dr. Pradeep. So I would like to ask Mr. Bissal. He uh, talked about this hub and spoke EMR. So can you please elaborate how this will help and what will be the impact of this hub and spoke EMR? Uh, Mr. Bissal? I think he's not there. So, Dr. Moriyama, uh, so
Yes.
what did you learn from through
Right.
presentation?
Yes. Okay. Thank you. So thank you for to all speakers to have it to share the very informative presentation with us. Actually, I'm a kind of a telemedicine guy that mainly focusing on the doctor to doctor education in the world. But in my understanding, before the COVID, it is very difficult to make it possible in the rural area. But nowadays, as the president mentioned, the how to say the network as an infrastructure have been improved dramatically, even in rural areas. So that now is a good timing to start something. So that actually, for the last few years, all the equipment, such as the dependent devices like the EHR or other how to say the measurement of the blood pressure or something like that, is well equipped in those areas. So that the next stage should be the collecting the data to show the effectiveness of this kind of the activities. So unfortunately, in Japan, still telemedicine, not education, doctor to patient telemedicine have not been implemented yet, well yet, actually. So still the government would like to force make it forward but still nothing happened in Japan. So I just would like the Nepal to be the leader of this field because you have a lot of needs. So that's why the showing the effectiveness of telemedicine is I hope to show you to, I hope you to show the effectiveness of telemedicine in your country. Thank you so much. I learned a lot.
Thank you, Dr. Moriam. You have been always inspirational for us. So you are just inspiring us to do more. That is very nice of you. And this time there were no participants from venue from Bangladesh. So were there any? Because we couldn't see from venue. I asked Rajan sir to participate, but he may be busy there. You also didn't go to Bangladesh too, this time. Dr. Moriam, You didn't go to Bangladesh?
No, I'm now still in our hospital, right? Because I'm wearing the white coats, right? Because due to the various reasons, we cannot send any staff, including me, to the venue this time. So I suppose that there is no the real venue in Bangladesh this time, unfortunately. Oh, totally virtual.
Okay, thank you. So here is Abhimanyu sir and Pranjal sir. So do you have any comments for today's presentations? Abhimanyu sir, are you there? Abhimanyu? Okay. So Vishal, are you there? So yeah, maybe they are not responding. So it was all very nice presentations today. With that, we would like to conclude our session, this rural healthcare session for 61 APAN meeting. We had a very nice time, and we'll be meeting again in 62nd APAN meeting after 6 months. So Ayumani sir, I think you are there. Will you please make some comments? Yes. Okay, then. Thank you all.
Thank you.
Thank you. Bye bye.
Thank you, Brad.
Thanks so much.